This week on the Backtable Podcast.
I think the streamlining has been a big difference and why my role has been very well received by the hospital. I think that's something that the other ENT hospitalists and I talk about frequently. What else can we use to measure? Not to say that we have to measure and fight for our worth, because we all know it works. But if we were to present this to someone who, say, has less background in clinical practice like we do, what are the metrics and things that really speak to them, such as if a department is interested in creating the job, how do they win over the stakeholders who would have to approve starting the service line?
Hi, everybody. Welcome to the Backtable ENT Podcast. We're a podcast that focuses on all things otolaryngology, and we've got a really great show for you today. Thanks for stopping by. Now, a quick word from our sponsor.
Hi, friends and colleagues. We're thrilled to announce the launch of Backtable Plus for ENT. Backtable Plus features bite-sized learning modules created by ENTs for ENTs. The content is designed to be searchable, organized, and easy to digest, making it perfect for our busy schedules. Best of all, it's completely free. We encourage you to explore the platform and share your thoughts with us. Go to plus.backtable.com, plus.backtable.com, and click on ENT courses. Your feedback is invaluable as we strive to make this resource as beneficial as possible. Happy learning, and we can't wait to hear what you think. Now, back to the show.
We have Dr. Annie Wang. She's an otolaryngologist practicing at Houston Methodist Hospital. And she's here today to talk to us about being a hospital-based ENT as a practice model in general and about her experience. So welcome to the show, Annie.
Hi, a longtime listener. I'm so stoked to be a first-time contributor. So thank you for having me.
Yeah, thank you for taking the time. Tell us about yourself and your practice.
I am a hospital-based otolaryngologist. Other names for it that is commonly used include ENT hospitalist, surgeonist, inpatient otolaryngologist. I've also heard acute care otolaryngologist as another term. All of these are different ways to say that I'm an ENT surgeon with focused time on doing ENT consults and procedures for the hospitalized patients. I practice at Houston Methodist, which is a level 3 trauma center hospital, which also with a large referral center, especially focused on transplant. So that also gives a certain patient population of patients who stay in the hospital long term, and it's not as practical to put all of their ENT needs to say follow up outpatient straight away, because for I'd say a plurality of the patients I see, sometimes they don't leave the hospital for at least 8 months.
So Annie, when you started your practice at Houston Methodist, was this practice model already in place? And that's sort of the position that was there for you? Or is this something that you're like, hey, there's a need here because these patients are here for a long time, or we need more continuity of care? How did this come about and how did you get it going?
When I was training as a resident at UTMB, I did rotations up at Houston Methodist, where I got a firsthand view of the hospital and just seeing the consult volume. At Methodist, having 3 consults in a day is considered a very light day. So after having rotated here, and that's where I really saw that the need, or at least the significant benefits of having a faculty member be dedicated to the inpatients at least a couple of days a week. So at the end of my rotation, I actually discussed with the chairman about creating this position at Houston Methodist. Like a year and a half later, we were able to start the inpatient otolaryngology service line, create the job. I'm currently in my second year of practicing here.
And how much of your time is spent being hospital-based? Is it 100% or just, a few days a week? Do you share this kind of position with somebody else too?
I am currently a dedicated inpatient 4 days a week. And then on 1 day a week, I have a half day of outpatient clinic to also help for post-discharges or for general ENT outpatients. And then also I have a little bit of OR block time that's dedicated for the for the inpatients. I'd say I'm 4.5 days inpatient and then half day outpatient.
And are these like shifts? So you have a hospitalist that's at the hospital doing all the like ED consults, inpatient consults from like 7 to 5? Or does this also take into account call, or how does that work?
When I negotiated for this job, I negotiated for a 6 to 3 Monday through Friday shift. In addition, we have residents, rotating residents, as well as our home residency program. So they also make up the consult service. They're typically the first line of the ENT who is called, and then I come in as faculty support. Depending on the time and the situation, I'm either seeing the consults with them or checking up on the consults. And then also I'm the de facto ENT for staffing consults and for inpatient ENT cases, such as tracheostomies, invasive fungal sinusitis cases, anything else that comes our way. I had a couple of bedside FNAs, ultrasound-guided drainages, neck abscesses.
Do you have an inpatient service then too, as well, for some of the patients that maybe you admit, or is this mostly a consult service?
We're mostly a consult service. So I oversee and manage most aspects of the consult service, except in cases where there is the significant complexity, such as anterior skull-based tumor or advanced head and neck cancer. Or if a patient comes to the hospital who's established with one of my partners, usually I talk with my partner and see which one of us would be the one to follow throughout the hospitalization. And then also that way I can easily coordinate outpatient follow-up when the patient leaves the hospital.
So for the ENTs that have like cases at the hospital, for example, like a neck dissection or, a head neck case that has to stay, are they then on your service? Or is the service that you run separate than sort of the inpatient service post-ops?
My service is separate from the inpatient post-ops typically. The only exception is that if our service was consulted, more often than not, the patient comes to my service. And then it depends on who does the surgery for them. If they're transferred over to, say, the otologist service or the head and neck service, we decide on that based on what each patient needs.
Yeah, that makes sense. And so you said you're a level 3 hospital. You have residents. Your team of residents, are they 100% on the consult service or the inpatient service, or are they also doing cases with other attendings during the day and then they leave the OR to see a consult and then contact you? Or how does that dynamic work?
I don't have a dedicated consult service I think it's also because we have a mix between the rotating residents, and we started our residency about 3 years ago. So right now it's still a lot of we're forming a lot of the first services and how we want it to be over the next couple of years. And right now, what works the best for us is that I have one resident that we round all the consult patients on in the morning, and then afterwards the residents are assigned to clinic or to OR. And then in the afternoon, or one of the residents start becoming free and they start seeing consults, if I'm still around, I come in, I see the consults with them, or am available to provide some immediate advice or assistance. When we have interns rotating, sometimes they have days that they're also dedicated to the inpatients or the floor, and that's when I work very closely with them. And it really depends on what kind of day it is and which resident I work the most with. I work with all the residents that come on service with us throughout the time that they're here.
Do you have any APPs that are dedicated as part of this team as well? Or do you foresee a role for APPs on this service?
I do not have APPs on the service with me, but some other ENT hospitalists at different institutions, such as Philip Allen at LSU and Beth Willingham at Emory, they have PAs. They have PAs who also help with the service. I know that there's a lot of interest in hiring APPs for a role like this at a lot of different institutions too. Definitely something to look into.
So take us through kind of like your day in the life. You mentioned that you round on patients in the morning. Do you have any patients where you're the primary for them, or mostly you're just consulting and there's a hospitalist or another team that's kind of their main doctor?
A day in the life is a little bit difficult because there's really no such thing as a typical day. It's whatever the hospital wants to bring me. But typically we round with the resident, a consult resident between 6 and 7. Afterwards, it's others finishing up other tasks such as rounding on the consult patients from overnight who are still in the hospital to check up on them, check in with some of my other patients, or if I have planned procedures, I go to those. I have a mixture of both inpatient and outpatient surgeries, and we schedule those. Sometimes we literally schedule those the day before, so that's what my schedule looks like tomorrow. In addition to working on the consult service and the inpatients, I oversee a lot of the quality improvement initiatives within my department. And so I'm also looking at our cases, also seeing what are the ways that as a service we can improve our outcomes, and also have ways that make the work easier on ourselves and on the hospital.
Was it hard to get block time because it sounds like, do you have like a little bit every day for an urgency, an abscess that hasn't gotten better that you can go? And how did y'all predict how much time to save for that? I would imagine that was tricky because you can't be the add-on every day at 5 p.m. That's not the point.
I have about a 3-hour period of block time once a week, and then with the possibility of adding on cases for the rest of the week. This block time was something that the ORs and the ENT service were trying to get off the ground before I started. But the issue was that I think that the other faculty, this sometimes ran into other faculties already planned block times or clinic times, and we were just not able to make it work before then. So this was something that our department and our OR always had in mind. The hard part was finding someone or a group of people who would consistently be able to staff. And so once I came on board, and then we also got a better gauge of the demand because I took over a large part of the inpatient surgeries. We then said, okay, well, let's start with a 3-hour time period to do at least 2 bedside tracheostomies in the morning as a first start, and then go from there. We'll reassess demand. I think one of the hard parts of the managing the hospital side is that it's not predictable. You can't schedule cases out weeks in advance to qualify for traditional block time. I think one of the things to anticipate if you're trying to add an inpatient ENT service to the hospital or to the department is how do you accommodate for these sudden changes or sudden need to change schedules, or how can you make your service flexible so that it can respond to a new high acuity consult on short notice, but also minimize the disruption to already planned cases and the more other cases that have been scheduled out much farther in advance. I think it's a struggle of all hospitals are trying to balance the demand for surgery and services from that have been already a long time scheduled outpatient, because we know that their schedules are getting booked out longer and longer, but also if an emergency comes in, it can't wait.
What day of the week is your block time? You put it in the middle of the week?
I know. I was thinking the same thing. Like, is this a Wednesday thing or a Monday thing after the weekend?
Yeah, I put it as a Tuesday, so that Monday acts as a buffer day. This is a day where also when I come back to work on Mondays, on the times I'm not on call over the weekend, I can also take over for the inpatients if my on-call faculty would like me to take over their care. And in that case, this also gives me a day to have cases or arrange cases to be posted for tomorrow, and to check in with all the inpatients from the weekend to see that, okay, that they are still ready for surgery, relatively optimized, and we made sure to get all the clearances and make sure that all their care is coordinated.
And is the OR, so for the other days where, a case does need to go and it doesn't happen to fall in within your block time, because you're like the consistent ENT add-on person, have you found that the OR is a little bit more forgiving or flexible or able to accommodate you a little bit better? Because I think for a lot of, with the on-call, it's always some add-on that ends up going at like, sure, we'll do 3, but not really. It's like 5 because then, the staff changes and that's right. That's some of the frustrations.
Definitely.
Yeah.
I think so. I think the other added benefit of me being dedicated inpatient for 4 days out of the week is that I've also started scheduling, say, trach surgeries. I'm not trying to add them on the next day because most of the time the OR schedule for the next day is already locked in by the time you see them. So I try to schedule it for 2 days down the line, such as if a consult for trach comes in on Monday, I try, and I also tell my residents, no need to try to add it on for Tuesday. The schedule's already pretty locked in. Look at Wednesday. If there are gaps there, we can do it anytime between 6 to 3. I can do it anytime between 6 to 3.
Yeah. So are you pretty good about consistently being able to leave at 3 then? Be honest, Annie.
I can leave at 3. Once it is all after 3 o'clock, all consults can go to my on-call partner. I'd have told my residents if this is a consult that you saw earlier in the day, they're already admitted, and I could see them in the morning, you can feel free to sign it out to me. But please don't call me at 8 p.m. or something.
So is your clinic, the Friday morning clinic, is that mostly filled with follow-ups then from your care that you provided from the consults or the inpatients that you saw? Is that most of your clinic?
My outpatient clinic is on Tuesday afternoons. Right now, we're looking at trying to find what is the best time to fit it in. But to actually answer your question, my clinics are filled with a mix of post-hospitalization follow-ups and new referrals for general ENT needs. I still see a little bit of everything and do a little bit of everything. Try as I might, I'm probably never going to convince the hospital to let me do a septoplasty on an inpatient. Then there's certain cases that don't need to be done inpatient, and it is more appropriately done in an outpatient setting. So also I like to keep up an outpatient practice. I like keeping a clinic spot open because a lot of times certain consults that I get from the emergency room, such as a nasal abscess, foreign body of the ear, otitis externa, we are better equipped to handle these consultations in our clinics instead. And as long as I'm able to get them appropriately moved and open a clinic spot for them, I've actually been able to safely discharge ER consults out of the ER, get them to clinic, get them the care that they need the same day. Our emergency room absolutely loves this new model when we can get it, because it's also, in clinic, we have all of our specialized equipment, and we have, I think, especially all the specialized equipment. Otherwise, you're trying to find what you can to bring to the emergency room, which might not be outfitted with the things that you need. They certainly don't have the exam chair that all of the specialized suctions or intranasal or things for our ear instruments. So that's been a one way that I've been seeing, is like paving out a way to improve ready access to our care, but while also decreasing the amount of time that our patients have to spend waiting in the ER.
Your elective cases that you are, scheduling in clinic. So for example, like your septoplasty cases, like you mentioned. So that gets scheduled in your block time, on your Tuesday block time.
Sometimes I choose to schedule it out with just on the regular OR schedule. For my outpatient cases, we treat these as if I'm just a regular outpatient ENT without block time, but we still get it done in a pretty timely manner. If we need to, yes, I can certainly schedule some short outpatient cases into my Tuesday block time.
But on your elective OR case days, you're still coming in and doing your 6 a.m. rounds, and you're still the consult person for the day, or just happen to have some cases booked that day too. Are you filling your that 3-hour block time that's for inpatient cases? Does that consistently fill every week?
It's been pretty consistently filling. I think sometimes consults seem to fluctuate in volume based on the month. And so then something new that I've been able to observe now that I'm fully dedicated in practice. If I don't have inpatient cases to fill the block time, and I do happen to have an outpatient case that we want to get done, I can post it in there.
In terms of trauma call, your role in airway, is it still pretty much the same, or do you feel like you have a greater role because now there is, a consistent person that's around for the, certain hours in the day?
For airway within the hospital, definitely, I feel like I've become one of the de facto ENT faculty that people get in contact with if they can't reach the residents via the consult pager. We don't get a lot of facial trauma because we're level 3, so I actually don't see a lot. I don't actually see a lot of it anymore.
And when you guys were getting this started, you mentioned some other places that have similar programs. And for people who are listening who are thinking like, maybe we should get this started at our department, what are some big things that you've kind of learned along the way? Maybe something that you tried and then you were like, oh, actually, that doesn't really work well, or things that other programs, kind of tips that they gave you that they've learned. Because it is a relatively new idea. I do remember in residency, like having a conversation with the co-resident at one point being like, I wonder if the hospitalist type model could be applied to ENT and you could just be a surgeonist and be in the OR all the time, be in the hospital. And then now here it is, there's, you're living it. So what can you share?
I mean, is this now the time to go on a little tangent about the history of the ENT hospitalist?
Let's do it.
Yay! So it's a ENT. So ENT hospitalist really started as a concept at UC San Francisco back in 2012. It was one of their graduates, Matthew Russell, started the program there. I think also to meet the demands for inpatient consultation and having a faculty that's consistently present and able to staff cases or be a sounding board for these for a lot of medically complex patients and timing of surgeries. And Matt Russell stayed in his position for 10 years, and he's since moved into a general ENT job at Massachusetts Eye and Ear. In that time between 2010 and 2022, a couple of other programs also started popping up. There was Philip Allen at LSU, Beth Willingham at Emory, and Chris Rasick at UPenn. Each of these ENTs had started in had spent time in private practice. They were looking for more of a career change at that point in their career, and they had just happened to talk with the academic departments about the possibility of having a dedicated inpatient faculty. In Emory's case, I believe it was because they were opening a second campus, and so the coverage was going to. They were anticipating that coverage was going to be more divided, and it was to their benefit to have a consistent ENT covering the campus that Beth now covers. And since then, I believe the departments are always changing, and there is more coverage between the two hospitals at more of a rhythm. But I think that especially for Beth's case, it was. They wanted to make sure they maintain consistent ENT coverage at one site. Chris Rasick's case, he adopted more of it's a classical surgeonist model where he was in the OR and helping cases as surgeons were essentially acting as a co-surgeon to help run two rooms. Don't know if I can say that anymore because it's not kosher to do that anymore. But it was also the surgeonist model at UPenn. It was to improve OR efficiency and having a co-surgeon second assist. So that's I think another possibility to look into if this is something that is what's causing some decreased efficiency or delays for the department or for the service. UCLA also has split between two campuses, so also the need for a consistent having someone for consistent coverage. But then Natalie Caden, who's the ENT hospitalist at UCLA, covers both hospitals. It just varies by the day of which one of where she needs to go and how many trips she needs to make.
So Annie, when you brought up this to your hospital, did you have to show the financial benefits of this? I feel like, is this something that you had to convince them? I feel like, meaning we think of, we generate the RVUs in clinic. That's where, we're not going to generate it in the OR, we're going to generate it in clinic. So, and then a lot of traditional, we think of, well, you might be on call while you're in the OR doing these consults, or you might be in clinic still on call fielding these consults. So in terms of the impact on the quote bottom line or financially, what can you tell us in terms of the model? Hey, actually, there's a lot of revenue that we're missing, or talk to us a little about that.
In terms of sheer consult volume, when I was rotating as a resident and just seeing the sheer number of consults, that's why I first got the idea of I could make a job and there could be money in this because in terms of billing, the faculty has to be present for the procedure, or the faculty has to see the patient in order to be able to fully bill for the consultation. And then financially, I'm tracking my charges, collections, and RVUs for the first year of my job. Of course, with the addition of a small half-day clinic, I've already made back my salary and collections in my first year. There's something there. I don't have solid numbers yet, but that is something I'm hoping to come out with and have more to report, more concrete numbers to report on soon. Because I think that it's until it's proven that there is a lost revenue from the inpatient and consult side, we won't know. Because traditionally, what we've been taught and what we see from billing and reimbursement is that outpatient pays more, and we're not going to change that anytime soon. This is also, I know that this was something that the hospitalists also were a problem, and something that they were running into when the hospitalist as a specialty first came to be. I've also, as part of my research for my job, I was talking with hospitalists about how they're billing and what they do for their services. Are they capped? How many APPs or residents or other ancillary staff do you have to support you? What are your hours like? And that was a part of how I researched and tried to adapt my job.
Yeah, I think a tricky thing, with being the person kind of on call for inpatient consults, is that you really have no ability to influence how many consults you're going to get, right? Whereas in the clinic, you open up a template with however many patients you decide you want to see. And, you in clinic, you develop a reputation for being the best surgeon for XYZ. And then you start having referrals coming in. And so now you're doing, over time, you do more and more of those surgeries because you become known as that person. And so in this position, do you, in your research, is there a disadvantage to being the person that's, doing the inpatient consults because of things like not having any sort of control over how much you're going to be able to do from a volume standpoint, and just the professional growth? How do you think about those types of things?
I think that in my experience, just by me being the consistent faculty, sometimes I've also noticed that the other doctors in the hospital, if they call me with a consultation, that it's more of a curbside, and if I can give them some advice and answers over the phone, and they feel, such as for a patient who is intubated patient who's failing their cuff leak test, they're thinking about a trach, and then asking for more details, I find out this is a tiny 100-pound woman intubated with a 7.5 ET tube. I discuss with them over the phone that maybe all they need is to be sedated and change out to a 6.5. If you get the cuff leak and you're already passing the SPTs, it could just be that the tube was too large. I've had multiple times the ICU has done the tube exchange without needing our service present, and they passed their cuff leak, they passed their SPTs on awakening, and then they were extubated without problem. So I've noticed that there's been an uptick of curbsides, and the ones that I can easily assess and triage over the phone. And because they know me and they know I do what I do and my track record in the hospital, they're more likely to do that. No consult needed. So I do have a little bit of influence on the inpatient service.
But I think it highlights sort of the metrics we use of how we calculate things, right? We can use clinic volumes as a way to calculate things, but the amount of coordination of care, complexity in terms of different services that might be managing a single problem together, or those 10 minutes that you have to take to look up the chart, see who the patient is, and then talk to the ICU, even with a curbside, that's still a lot of time and decision making.
Yeah.
And so I guess it's, do you leave a note in the chart when you've had that? Is there a way to capture those, right? If we're talking about how do we quantify this and make it a little bit more calculable to bring in, I would consider asking for the consult so that you can bill for it. Because I know, I think you're kind of thinking like a resident, but I think
I think, but I think you're bringing a ton of value to the team in the department, right? It reminds me, like, when I used to like wait tables when I was a kid, right? When you were done, like at the end of the night, you tip out to the bartender, you tip out to the food runners. And so like in the department, you're bringing a lot of value by being there at the hospital and seeing these consults so that your colleagues who are trying to operate or trying to run clinic are not split between that. And so there should be a way to tip out to you for your service. I don't know if other programs have like developed. I think Gopi is right. It's about the metrics that exist haven't, this such a new idea that the metrics don't quite fit.
And the work is hard and it's busy.
It is.
It's not I sit there for 2 hours and wait for the consult. Like there's always something going on. It's a full day. It's very busy. And sometimes the acuity, it's a lot of complex coordination of care as well. And so sometimes it is really difficult to kind of, how do we calculate it, capture it, measure it?
Like financially, I think that the fact that we're now able to, as the ENT hospitalist, I can bill for 100% of the consult is by itself already showing the numbers. So we have that, and then also RVUs. And then we also keep in mind that my collections and RVUs are an incomplete picture because sometimes we're consulted on a post-op patient of one of my partners, and my partner takes the consult. If it's an overnight ER consult and they have no reason to be admitted, there's no reason to hold them there until I'm back. And we say, no, there's no need. So I can't bill for those all of the time. But in terms of sheer volume and collections, I can see my own impact, and financially, I think my job is solvent. So that's to reassure everyone out there. And then in terms of other things that we can potentially measure, I think it's going to depend on how each ENT hospitalist shapes out their job and what they want to focus on. Another thing that that my department is looking at is, because I oversee the quality metrics and now length of stay index, we're seeing that right now we're looking at the correlation of how have our quality metrics and length of stay index been trending since I've started here. We have noticed that our length of stay index has us consistently gone beneath 1 since I've started here. Obviously, this is a department-wide, hospital-wide effort, and I can't take all the credit. Maybe most of it.
Take it. Go ahead and take it.
Yeah. It's all started after I got here.
Yeah. That's awesome.
And so other things that to look at are also the ER waiting times. When I work with the residents and I'm present for, say, the scope exam after the procedure, the residents and I can discuss the plan with the patient right then and there. There's not a need to sign out with a phone call, a text, an email, delayed response. So, and our emergency room has already multiple people have commented to me that ever since I've started, our ER's ability to quickly get our ENT consult patients triage has dramatically increased. All of this I know is our quantitative statements. We have the data to look at the qualitative stuff. I need to go over it.
Yeah, I think there's no doubt that you're bringing a lot of value and that you are known in your organization now that there's like some, a go-to somebody to be able to staff these consults. And from a patient standpoint, I'm sure they appreciate that too, to not have the junior resident say, okay, I'll be back. And then then they were back with the senior resident. Yeah. And it's like, okay, we're going to talk to our attending. We'll be back. It's I imagine it's a much better patient experience.
Yeah, I think the streamlining has been a big difference, and why my job has been my role has been very well received by the hospital. I think that's something that the other ENT hospitalists and I talk about frequently. Like, what else can we use to measure? Not to say that we have to all measure and fight for our worth, because we all know it works, but if we were to present this to someone who, say, has less background in clinical practice like we do, what are the metrics and things that really speak to them, such as if a department is interested in creating a job, how do they win over the stakeholders who would have to approve starting the service line? And it's hard because there's a lot of qualitative measures that we need to that we need to look at. I think that one other area to look at could be HCAHPS scores, because of the hospital surveys apply to all the hospitalists, primary care and specialists. So average HCAHPS scores by department before and after they have a dedicated inpatient specialist, and seeing that from that point of view. I believe until 2023, quality metrics and length of stay index were only counted on inpatients and inpatient surgeries. So nowadays, because there's going to be additional metrics regarding volume and quality metrics and Press Ganey for outpatient surgeries, that's a little bit diluted. But at the end of the day, quality metrics and quality rankings is still largely dependent on patient outcomes, such as post-discharge unexpected readmissions, complications, morbidities, and mortalities, especially for the inpatients who are more likely to have complications. So I oversee a lot of that for my department. And so I think there's another avenue or place to look if you're hiring that for someone who does quality research in addition to clinical practice.
Yeah. So Annie, when you think of the hospitalist ENT model, do you have to be a busy tertiary quaternary care hospital to support that? Or is it, hey, if I have a person that's has dedicated time, it will come? Like most hospitals wish they had somebody that they could, could call, you build it and they will come, or no, at the minimum, you're going to want an IC, a certain number of bed hospital or certain, number of bed ICU or et cetera, et cetera.
I think that ENT Hospitalist has developed at major academic centers so far because initially they need a certain volume to persuade the department in favor of, okay, let's try hiring someone. Because what we have right now, while it is functional, is not at its best. How about we hire someone dedicated to see how much it can improve? Since I've started, I do think that we hire someone, more will most definitely come. I've been doing a lot more increasing amounts of bedside vocal cord injections for ICU patients. We have a sizable lung transplant program, so we're called frequently for dysphonia and dysphagia. From what I have noticed and talking with my partners, I think that the ICUs have definitely increased the number of our consultations that have led to more vocal cord injections, because I've been able to consistently come to bedside, get this done promptly, and get them on their way to talking better, maybe marginally improving their swallow, and getting their care on their way.
Yeah, I think that's a good point. Are there other types of consults that would typically be referred to, follow up as outpatient that, are there some examples of things you've been able to say, like, oh, you're going to be in the hospital for a while, let me just do this while you're here?
I think for my role, I think any procedure that we do in office, outpatient, or in the operating room, I think comes back on the table and to consider for a lot of our patients. There's a couple of times I had this patient who needed a revision FES because she was in the hospital to be worked up for heart and kidney transplantation. She cannot leave the hospital with or without the transplant, but the transplant committee was saying that because of the evidence of persistent chronic sinusitis, we don't want to list her for transplant until after she gets her FES and is shown to be without evidence of a sinus infection. So certainly not. This is not one that you can move to outpatient. So I said, well, this is the situation. We should do it. And there was also another patient where profoundly pancytopenic with a relapsed leukemia, and the oncology team wanted to escalate their chemotherapy, but had persistent signs of chronic sinusitis, and said we can't give him more chemotherapy unless he gets the surgery. So and then sorry, I have a lot of stories. And then there's a
You've been in the trenches.
Yeah. Another patient who was being worked up for heart transplant with a 7-centimeter thyroid nodule. He was needing significant pressor support that he could not go to IR. So I was called in to do a bedside FNA. So things like that. I think that any procedure that you think about as you can do in the outpatient setting, ER, office, ambulatory surgery center, it's something that now, before, just because to meet the demands of service and because the other faculty their schedules are almost often very much packed, we had to say we can't realistically do this surgery while they're inpatient. So so whatever could be moved to outpatient, we had to, because we did not have the time or the resources. Now that since I've started, we have someone who's able to do it. I can post the cases. It just comes down to, well, can I find a good gap in the schedule where it's available? And the anesthesiologist, the charge nurses, everyone knows what I do, knows that I'm the one who's going to be calling about the inpatients. I see there's a little gap next week. Can we do it?
Do you have audiology? Do you have the ability to do any audiology in the hospital? Like if you were to, like for these patients that might have a, sensory neural loss related to their chemotherapy or, things like that. Does that ever come up or not really?
I do not currently have inpatient audiology support. Mainly that also some of the patients are just not safe to leave the hospital setting to be moved over to the audio booth. I don't have inpatient audiology support.
Just a tuning fork, right?
Basically. And the tone generator from my phone.
There you go. Annie, do you feel that the hospitalist model is different than in the peds world? A lot of times we have surgeon of the week who's on call, and it's like pretty much being sort of the inpatient consult hospitalist for that week.
Yeah.
Is that different when you're the full time? Like, do you feel like there's different in terms of quality or consistency when you can provide that sort of same person or same one or two people?
Yeah.
More than just a week at a time?
I think that there's pros and cons to both models. Because I have a dedicated inpatient, I see people weeks to months apart. Previously, our service might have been consulting on the same patient for 4 different chief complaints, such as an ear complaint, nosebleeds, voice concerns, and then they're signed out to a different faculty each time because of that's the faculty on call or that's the subspecialist. Whereas now, if this patient is known to me and I know them, we have a more established continuity of care and standardization of care. In some cases, maybe you really do need a second set of eyes or a subspecialization, and up to the service to decide when that's appropriate. I think that to speak for a surgeon of the week model, I think that's also one that allows each surgeon to be flexible with their time, and they can plan out. They know in advance which week they're there. They can also adjust their schedules accordingly, such as maybe they're naturally booking fewer surgeries in anticipation and for add-on cases. But if the add-on cases don't come, well, hey, naturally becomes a lighter week. So I think you win either way. I think that these models are the different ways that we're all looking to address the same problem.
The kind of main problem that it's addressing is just the ability to kind of efficiently take care of inpatients while you're kind of juggling all the other parts of ENT, which are, I would say the majority is outpatient, right?
Yeah, because I think that the pivoting from inpatient to outpatient also takes a lot out of your day in terms of time, energy, and focus. I mean, the people who are hospitalized are some of the sickest and most complex people that we take care of. So I think that there are ways that, to people who need more complexity, they just might need extra time. That extra time that they need really stacks up very quickly for everyone. So rather than having, say, dividing this among everyone, I think the hospitalist model, we look at what about if we concentrate it to dedicated member who then works in the consistent setting hospital rather than the clinic, but also with access to the supplies and equipment they need to help to take excellent care of the patient.
Yeah, it's so true. Like I feel like I'm using different parts of my brain or like reaching into different like knowledge bases, like when I'm taking care of a patient in clinic versus in the hospital. Like it's typically a lot of like, it's different pathology. The acuity is different. The like timeliness, is very different, right? I assume that you take vacation sometimes. So what happens then? What's the protocol for the week that Annie's out? Does everybody have to split up the days? I bet they really appreciate you that week. That's when they're like, oh God.
Yes. So when I take vacation, the consult staffing goes back to how it was before I started. Essentially, the residents decide who to sign out the consult to. In the daytime, they have the choice between the ENTs who are already in OR or in clinic or the on-call ENT. And then if it has a subspecialist need, they assign it out to the subspecialist, and then the residents look and find the times and find staffing for the inpatient surgeries. Since I've started, I have had multiple other faculty start asking me when I'm next going on vacation.
They don't know their own schedule, but they know Annie's. They got to mentally prepare for that week.
Yeah.
Like, oh God, Tuesday's going to be rough.
I try to also, when I know I'm on vacation, I try to tell the faculty beforehand, out of courtesy, because they know to expect an uptick in consultations. Just because, yeah.
Well, as we start to round it out, what other pearls or insight or perspectives from your experience would you like to leave our listeners with?
Yeah, I think that for the ENT hospitalist, one big reason to consider, start thinking about how to build in a ENT hospitalist service line is that from what I see, I think the patient cares always get more and more complex, especially as we are continuing to advance medicine. I think that there might be a point where we have a subspecialist for every single diagnosis a patient might have, because there's so much nuance that we want to consider. But because patient complexity seems to concentrate on the inpatient side, I think it's definitely worth considering having a subspecialty presence there. In fact, around the Methodist Hospital, I've met some people who are kind of de facto or officially become the inpatient ophthalmologist, the inpatient pulmonologist. And I know that orthopedics and acute care surgery is experimenting with models like this. One of the big benefits of having an ENT hospitalist is you have a faculty who has significant experience in, so I would say, playing scheduled Tetris and getting the cases on the board, getting the inpatient care move forward, especially with tracheostomies. These patients they have, like, their airway is secured. So this does, in some ways, make them they're considered less urgent surgeries to get to, but also they cannot move forward in their care until they get the trach. So balancing that and being able to schedule these out a little bit farther time to give the anesthesiologist, charge nurses, and the OR such an advanced notice to just officially put a set it in stone, secure down that time with faculty is going to be there. I think that's been one of the most impactful parts of my role in the hospital.
I think that rounds it out. We've already asked our final pearl, so we're good there. So we'll just say thank you. Annie, are you on any social media if any of our listeners have questions for you?
I'm on Instagram at Southern Oto Hospitalist. Just a forewarning, I know I should post more on it. I don't, because the hospital loves to find ways to keep me busy. If you guys have any questions, you can feel free to reach out to me on there. You can also email me, rwang@houstonmethodist.org.
Awesome. And we want to do a shout out to Yang, because Z was the one who we trained with, right, in residency and fellowship at UT. That was like, hey, you need to get Annie on. It's a great topic. So
I knew if I started talking to enough ENTs around Texas Medical Center and say, I would really like to be on this podcast, it would come up.
Well, thanks for coming on and thanks for contributing.
Thanks for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _Backtable ENT on Instagram, LinkedIn, or Twitter. Backtable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening, and see you next week.